Over the past few weeks, I've had several patients ask me the same question. Is gabapentin going to ruin my memory or give me dementia? See, this question is related to gabapentin making the news this past summer due to the publication of a new study on its potential effects on memory impairment and dementia. So let's talk about what gabapentin is FDA approved for real quickly. It is approved for partial seizures, postherpetic neuralgia, nerve pain, restless leg syndrome, and it is also used off-label for fibromyalgia, chronic pain, anxiety, alcohol dependence, essential tremors, and bipolar disorder. In my profession, I prescribe it a lot. So if you're taking it or you're considering if you want to take it, this question deserves a real answer. Not scary headlines, not dismissive reassurances, the actual science. And that's what we're going to get into. Hi, my name is David Osuji. Let me introduce myself real quickly before I get into it. I am a psychiatric mental health nurse practitioner in the Dallas area. I will explain this information and you'll learn what gabapentin actually does in your brain, what the new dementia research really means for psychiatric patients specifically, because that's my focus, and the exact framework that I use to prescribe it as safely as possible. All right, so let's get into it. What does gabapentin actually do? Gabapentin was originally developed as an anti-seizure medication. As I mentioned, it is FDA approved for seizures, restless leg, and nerve pain. But in psychiatry, I use it off-label for anxiety disorders and alcohol use disorder, especially during alcohol withdrawals and to reduce cravings. Here's the key. Gabapentin doesn't work like a benzodiazepine, even though its name sounds like or has GABA in it, which GABA is the calming neurotransmitter for the brain. It doesn't directly bind to the GABA receptors. Instead, it blocks voltage-gated calcium channels in the brain, specifically the alpha-2 delta subunit. Now, that's a lot of words, but think of it as turning down the volume on an overactive nerve circuit, not hitting the mute button like a sedative would, but just turning down the volume a little bit. See, this mechanism of action matters because it explains how gabapentin can be helpful in conditions of high neuronal activity. In alcohol use, in pain, in anxiety, gabapentin reduces the neuronal excitation. Also, why it can cause side effects like drowsiness, dizziness, or that foggy feeling that some people describe. But this mechanism of action also explains where the potential for cognitive issues come from. Memory/brain recall function best in the optimal neuronal activity. So when the neurons are firing, we can recall information, we concentrate better. It's like the note taker is online. But when those neurons are dampened, when we dampen the signal or the firing to control for other conditions like pain or anxiety, it does not negate the fact that the overall signal in the brain is turned down. Now, when you turn that signal down for an extended period of time, like even years, what do you think will happen? Right? Remember, if you don't use it, you lose it. That's how life functions. The brain and brain activity and neuronal firing is no exception to these rules. If you're not using your brain activity because you're dampening the signal, you eventually lose the ability to maintain those signals. I know that's an oversimplified explanation, but that's the best way to kind of convey it so it's easy to understand as far as how gabapentin works and how it affects potential memory and recall. Now, let's talk about the headlines. What sparked all these questions from the patients is a major study published in July 2025 that looked at over 26,000 adults with chronic lower back pain. The researchers found that people who received 6 or more gabapentin prescriptions had a 29% higher rate of dementia, dementia diagnosis, and an 85% higher rate of mild cognitive impairment within 10 years. The numbers looked even more striking in younger adults. And in people aged 35 to 49, dementia risk more than doubled. And their MCI risk, MCI risk is mild cognitive impairment risk, more than tripled. That sounds very scary. I get it. Very scary. But here's what most headlines did not tell you, did not mention. This study looked at the chronic pain patients, not psychiatric patients. And there are very critical differences that we need to mention. First, this was an observational study. It shows an association, not a causation. People prescribed gabapentin for chronic pain often have multiple medications on board, limited mobility, chronic inflammation, and other health conditions that independently increase dementia risk by themselves. The study tried to control for these factors, but you cannot fully separate them. All right. Second, and this is crucial, people with chronic back pain taking gabapentin long term are often taking it along other medications like opioids, muscle relaxants, benzodiazepines, sleep medications, and they're often older, less physically active, and taking them at much higher doses for many years. That's a very different picture from someone in their 30s or 40s who's taking gabapentin at moderate doses for 3 to 6 months to manage anxiety or early alcohol recovery. Okay, so the populations are different. Chronic pain and psychiatric populations completely different. So what does the research actually show for people using gabapentin the way I prescribe it for anxiety and alcohol use disorder short term? Here's the evidence base. Multiple randomized controlled trials show that gabapentin is effective for social anxiety disorder and can help with severe panic disorder when first-line treatments have not worked. The evidence for generalized anxiety disorder is mixed. Some case reports show benefit, but we do not have any large controlled trials just yet. Now, for alcohol use disorder, the evidence is much stronger. Studies show that gabapentin can reduce cravings, prevent relapse, especially in people with high withdrawal symptoms, and it can improve sleep and mood during early recovery. So one study found that 41% of people with significant withdrawal symptoms maintained abstinence on gabapentin compared to just 1% on placebo. So it is beneficial. Now, cognitive effects. Studies in healthy volunteers and epilepsy patients taking gabapentin at standard doses found minimal to no cognitive impairment. In fact, one comparison study found that gabapentin showed subtle cognitive enhancing effects when compared to other medications: better attention, better concentration, and inhibition. The key phrase there is at standard doses. When researchers tested higher doses in older adults or people already at cognitive risk, they did see increased sedation and some attention issues. But in younger, healthy psychiatric populations using moderate doses for short term, the cognitive profile looks quite different from what we're seeing in chronic pain studies. Let me break down why chronic pain studies may not predict psychiatric outcomes. Dose and duration. In anxiety and alcohol use disorder care, I typically use 300 to 1200 milligrams daily for weeks to months, not years. Chronic pain protocol often involves 1800 to 3600 milligrams daily indefinitely. Polypharmacy. My patients taking gabapentin for anxiety usually aren't on 5 other sedating medications. Chronic pain patients often are. Age and baseline risk. Most of my gabapentin patients are under 65 with no existing cognitive issues. The dementia studies focused heavily on older adults or those already at elevated risk. Indication. Anxiety and alcohol recovery are treated with the goal of eventually tapering off medication. Chronic pain is often treated indefinitely because the pain just doesn't go away. See, does this mean there's zero risk? Absolutely not. But it means that 85% increased MCI risk or mild cognitive impairment risk that you read about, it probably does not apply to a 38-year-old taking gabapentin for 3 months while working through cognitive behavioral therapy protocols for anxiety. Context is everything, and context absolutely matters. So here's my framework and how I prescribe gabapentin. I follow these 5 principles. 1, it is not first-line treatment. For anxiety, I start with evidence-based first-line treatments like SSRIs or SNRIs. For alcohol use disorder, I use naltrexone and acamprosate. They come first. Gabapentin is my second or third option when standard treatments haven't worked or aren't well tolerated. 2, lowest effective dose, shortest necessary duration. I start very low, 100 milligrams once or twice a day, and increase it slowly based on the response. And I build in a reassessment timeline from day 1. We are not automatically refilling this medication for years. 3, I'm extra cautious with certain patients. If you're over 65, have any cognitive concerns, take other sedating medications, or have a history of substance misuse with opioids, we have a very detailed conversation about risks versus benefits. And sometimes gabapentin is just not the medication for you. Number 4, I monitor actively. I tell every patient, if you notice worsening memory, trouble finding words, new confusion, or feeling significantly slowed down, that is a reason to check in immediately. We may need to adjust the dose or taper it off. And I ask about these symptoms at follow-ups. I don't wait for the patient to be the one to bring them up. And 5, I never stop gabapentin suddenly. Gabapentin needs to be supervised and tapered off, especially if you've been taking it for an extended period of time and or have a seizure history. Stopping abruptly can cause withdrawal symptoms or seizure risk. Remember, it decreases neuronal excitation. So if you stop it abruptly, you can have a rebound effect, like a spring that was compressed and you just let it go. It's going to bounce and go everywhere versus releasing that spring slowly. So these principles aren't about scaring you away from using the medication. They're about using it in a very careful and thoughtful manner, right? So what you should do, let's talk about that. If you're taking gabapentin right now and you're worried about your memory, here's my advice. First, don't panic. Don't just stop it on your own. The dementia associations are not proof of causation. Remember that. And they come from populations that look very different from anxiety or alcohol use disorders. But you do want to pay attention, track your memory and your concentration. And if you or your family notices changes, document them, write them down, and bring it to your appointment so that you and your provider can have a conversation about it. And you want to ask your prescriber questions like these. Why gabapentin specifically for me? What is our target dose and timeline? When will we reassess whether I still need it? And what should I watch out for? See, if your doctor says something like, we're going to be on this medication indefinitely, absolutely, you want to push back on that. Ask about the plan for evaluating the tapering and for switching to non-medication strategies, especially for anxiety, because there's plenty of other non-medication strategies that you can learn through therapy. And if you are on multiple sedating medications, gabapentin plus a benzodiazepine plus an opioid plus a sleep medication, that's a conversation that needs to happen. The combination of all those medications increases the risk beyond gabapentin by itself. All right. So here's my bottom line as a clinician. Can gabapentin affect your memory? Yes, absolutely it can. Some people experience brain fog or inattention symptoms, especially at higher doses or when combined with other sedating medications. And long-term use in certain populations can be linked to higher rates of cognitive issues. Does that mean that everyone taking gabapentin will develop dementia? Absolutely not. The current data shows that association in specific high-risk populations, not proof that gabapentin causes dementia. And for many psychiatric patients, the benefits, better anxiety control, successful alcohol recovery, improved sleep, can outweigh the risks when it is used carefully and short-term. My job isn't to say gabapentin is good or gabapentin is bad. It is to match the right tool to the right person at the right dose for the right length of time with full transparency about the trade-offs. If you have found this video to be helpful, drop a comment with your biggest remaining question about gabapentin. That's going to help me choose my next topic for the next video. And if you want to see how I taper people off gabapentin or what alternatives I use when it's not the right fit, let me know in the comments. And always hit the subscribe button so you don't miss the next video. Thanks for watching, and remember, informed decision is better than scary headlines every single time. All right, see ya.